Hi, my name is Daniela, and this is my presentation called Hope for Parkinson's. In this presentation, I'll discuss the newest research and treatments for Parkinson's that give us hope for the future of these patients. So, before I begin, I would like to dedicate this presentation to my grandma that battles with Parkinson's disease. It was her battle that actually opened my heart towards neurology, and I hope one day I'll be able to help others regain what the disease has taken away from them. So, in order to understand the treatments, we must first understand what is Parkinson's disease. So, Parkinson's is a chronic progressive neurodegenerative disorder of the dopaminergic neurons in the substantia nigra, which is the part of the brain that is responsible for movement. So, on this map, we can see the prevalence is higher in North America, East Asia, Western Europe, and then there's areas where the prevalence is lower, like Russia, South America, Africa. Well, that may not indicate true prevalence if there's limited neurological care, but roughly this is how the distribution of Parkinson is around the world. And it's calculated that there are around 10 million people that suffer with the disease worldwide, and it is the fastest growing neurodegenerative disorder and the second most common after Alzheimer's. And experts project that the numbers will double in the next 2 decades. So here we have the pathogenesis and clinical findings. So starting at the top, several initiating factors contribute to the neuronal degeneration. So genetic vulnerability, such as LRRK2 gene, which we'll talk about later, oxidative stress that leads to mitochondrial dysfunction, faulty immune regulation that drives chronic neuroinflammation, abnormal protein handling, which leads to misfolded alpha-synuclein, which is the hallmark of the disease, and of course, the environmental factors like toxic heavy metals, pesticides. These all lead to decrease of dopaminergic neurons. So eventually, after this, we have the accumulation of Lewy bodies, which can lead to disruption of cellular metabolism, apoptotic neuronal death. So eventually we'll have loss of the dopaminergic neurons in the striatum, and there will be altered balance between the direct and indirect basal ganglia pathways. So normally dopamine um, stimulates the direct pathway via the D1 receptors to promote movement and inhibits the indirect pathway via the D2 receptors in order to suppress unwanted movement. But when those dopamine levels fall, the direct pathways will become underactive and the indirect pathway will become overactive. So the net effect is increased inhibitory output from the globus pallidus interna and substantia nigra pars reticulata to the thalamus. The suppressed thalamocortical excitation and reduced motor cortex activation will produce the cardinal signs that we know of Parkinson, which are the bradykinesia, hypokinesia. Patients have masked faces, so their faces appear frozen. Shuffling gait, resting pill rolling tremor are very characteristic of the disease. Patients will often also have things like dysautonomia, which is characterized by orthostatic hypotension, constipation. Patients can also experience sleep and mood disturbances, cognitive decline, and psychiatric manifestations like anxiety and depression. So basically, it's a multi-system neurodegenerative process that begins with the alpha-synuclein pathology and it will culminate in widespread network dysfunction. So in order to it's important to understand these mechanisms because all of the current medications basically aim to modulate the levels of dopamine in the brain. So basically, we will try to either restore the dopaminergic function or modulate the basal ganglia circuitry to rebalance motor control. So the cornerstone remains levodopa for treatment, which is a dopamine receptor. It's a dopamine precursor that crosses the blood-brain barrier, and it combines with carbidopa, which is a peripheral decarboxylase inhibitor, which prevents the early metabolism and reduces side effects like nausea and hypotension. We have also things like dopamine agonists, like pramipexole, which will directly stimulate dopamine receptors. They can be used as initial therapy in younger patients or an add-on later on. We also have a medication class of MAO-B inhibitors like salicylic, rasagiline, which block the dopamine breakdown and may provide mild symptomatic benefit with possible neuroprotective effect. Similarly, we have the COMT inhibitors like entacapone, and this can prolong the action of levodopa by reducing its peripheral degradation, which helps to manage the wearing off fluctuations. Another class of drugs is amantadine, which offers a modest improvement in motor symptoms, and it can help reduce levodopa-induced dyskinesia through the NMDA receptor modulation. Anticholinergic agents, they're less commonly used today, but they remain useful for tremor-predominant Parkinson's in younger patients that don't have cognitive impairment. For advanced or refractory cases, deep brain stimulation or subthalamic nucleus or globus pallidus interna can modulate the abnormal firing. And finally, some non-pharmacological managements, which are just as important, like physical therapy for gait and balance, speech therapy for patients with hypophonia, and occupational therapy that can help the patient maintain their independence. So these therapies do aim at preserving quality of life of the patient, but now the approach is shifting towards um, neurotherapies. So we would like now to be able to slow the progression of the disease and restore function. So there are different stages of the disease and certain fronts that research is working on are metabolic, anti-inflammatory therapies, microbiome, regenerative gene, and device tech. So one of the most exciting new studies that came out this year in the New England Journal of Medicine, the LixiPark trial, which basically tested lixisenatide, which is a diabetic drug that activates GLP-1 receptors in patients with early Parkinson's disease. So we know of GLP-1 drugs for patients in type 2 diabetes because they improve insulin sensitivity and reduce inflammation, but they can also have neuroprotective effects and they can reduce oxidative stress, inhibit neuroinflammation, and support neuronal survival. So basically in this trial, it was a phase 2 randomized double-blind placebo-controlled trial where participants were patients with early Parkinson's disease. And basically they had the intervention they had were daily lixisenatide injections and or placebo for the period of 12 months. So for those 12 months, patients on lixisenatide showed almost no motor worsening, while the placebo group got about 3 points worse on the Unified Parkinson's Disease Rating Scale. So the benefits even lingered slightly 2 months after stopping treatment, which can hint at possible neuroprotective effect rather than just a symptomatic one. The trade-off was tolerability because some of the patients did experience nausea and mild vomiting, but that is common with GLP-1. So overall, it was found to be safe and is the first convincing signal that we might slow Parkinson's progression with a metabolic or anti-inflammatory pathway, not just dopamine replacement. In recent years, research has shown that Parkinson's disease doesn't just affect the brain, but it also affects the gut-brain connection. Many patients experience constipation years before motor symptoms appear, and studies show that the gut microbiome is altered in Parkinson's disease. So the key idea here was that the gut microbiota can influence brain inflammation, dopamine metabolism, and alpha-synuclein aggregation. So the goal is to restore a healthy microbiome and possibly slow the disease. So the Journal of American Medical Association published a study in 2023 where patients with Parkinson's disease received either colonic fecal microbiota transplantation, where a transplant of a stool from a healthy donor was given, or they received placebo treatment. Researchers measured changes in motor symptoms and gut microbiome composition, but the study did not find significant improvement in motor or non-motor symptoms compared to placebo. However, it did confirm that it can safely alter gut microbiome composition, and there were no major side effects that occurred. So the lack of clear clinical benefit might also be due to donor variability, short follow-up, or differences in microbiome response. And interestingly enough, the placebo group also showed some microbiome and symptom change, and that can be possibly due to bowel cleansing procedure itself. So that also needs to be tested if it can help. Another exciting thing with stem cells. So there was a phase 1 trial of human embryonic stem cells derived dopaminergic neurons. So the goal was to test if the safety and feasibility of transplanting dopamine-producing neurons derived from human embryonic stem cells into patients with Parkinson's disease. So researchers used embryonic stem cells and guided them to develop into dopaminergic neurons, the same type that degenerate in Parkinson's disease. These lab-grown neurons were transplanted into the putamen of Parkinson's disease patients, and there were two cohorts with cohort A low dose, cohort B with high dose, and patients also received immunosuppressive therapy to prevent rejection of the transplanted cells since they came from another person. They did follow up about 2 years of MRI, PET scans, clinical motor assessments, and phase 1 showed that no major immune reactions, tumors, or graft overgrowth, so it appears pretty safe. And there were some improvements in motor scores, which is exciting news, and dopamine uptake in PET imaging, suggesting that the transplanted neurons were functioning. But this is preliminary. The trial was not designed to prove full clinical efficacy. So another phase 1/2 trial of induced pluripotent stem cells was done, and this one, the goal was to use patient-specific stem cells instead of embryonic ones. So this reduces the ethical concerns as well as immune rejection. So the way they did it, skin biopsies were taken from Parkinson's disease patients. Skin cells were reprogrammed into induced pluripotent stem cells. These behave like embryonic stem cells, but are genetically identical to the patient. Then these cells were differentiated into the dopaminergic neurons in the lab. And after quality checks, they were transplanted into the patient's putamen. Because these cells are self-derived, patients did not need strong immunosuppression. And basically, again, it showed that it was safe, no tumors or inflammatory response. Motor function did improve modestly, and PET imaging confirmed increased dopamine synthesis. This approach showed that autologous induced pluripotent stem cells therapy is a feasible option. So now for aromatic L-amino acid decarboxylase. So this is the enzyme that converts L-DOPA to dopamine in the brain. In Parkinson's disease, dopaminergic neurons, which make this enzyme, degenerate. So even if the patient is taking L-DOPA, they can't convert it efficiently into dopamine anymore. So the goal of this study was to use gene therapy to deliver a deliver a working copy of the AADC gene directly into the putamen, a dopamine-targeted region, to restore dopamine production. So they used adeno-associated virus vector carrying the gene and delivered it into the putamen using MRI-guided stereotactic neurosurgery for precise targeting. So there were three patient cohorts that received increased doses of the gene therapy. Cohort 1, low dose, uh, cohort 2, medium dose, and cohort 3, high dose. And the results showed PET scan showed the enzyme activity that there was 13% increase in the enzyme activity in cohort 1, 56 in cohort 2, and 79 in cohort 3. Also, patients in cohort 1 decreased their anti-Parkinsonian medications by 15%, in cohort 2 by 33%, and in cohort 3 by 42%. And at 12 months, the patients reported more on-time hours, which are hours with good mobility and no dyskinesia, and in general, better quality of life. Another exciting research is the LRRK2 inhibitors. So this stands for leucine-rich repeat kinase 2, which is a protein involved in several cellular processes like vesicle tracking, inflammation, autophagy. So mutations in this gene are among the most common genetic causes of familial Parkinson's disease, and they're also found in sporadic cases too. When the mutated LRRK2 becomes overactive, it phosphorylates other proteins successively, and this will disrupt dopamine neurons' function, leading to neurodegeneration. So the goal of these inhibitors is to block the overactive kinase function and thereby slow or even stop neurodegeneration. So in this study, they found that the inhibitors are being developed to reduce abnormal phosphorylation and restore normal cellular signaling. They can reduce alpha-synuclein aggregation, neuroinflammation, and mitochondrial dysfunction. But because these are expressed also in other organs like the lungs, kidney, GI tract, it is important to monitor for systemic side effects. So the enhanced kinase activity contributes to both motor and non-motor symptoms. And the inhibitor showed promise by reducing the neurodegeneration in animal models, improving neuronal survival, and dopamine transmission. Another research paper. So Ambroxol, what is Ambroxol? Basically, it is a common expectorant that we use in cough syrups. But beyond its respiratory function, we can also use Ambroxol to increase the activity of the enzyme glucocerebrosidase, which is encoded by the GBA gene, which is often mutated in Parkinson's disease, especially the cases of Parkinson's disease dementia. So in these patients, with the mutation, the activity of glucocerebrosidase is reduced, which leads to accumulation of alpha-synuclein, contributing to neuronal damage. Ambroxol can cross the blood-brain barrier and boost the enzyme activity, which will help the cell's lysosomes to clear alpha-synuclein and the toxic metabolites. So essentially, it will enhance exocytosis and help clean neurons from the waste products. So the way this trial was designed, patients with Parkinson's disease dementia were randomized to receive Ambroxol or placebo. The goal was to assess safety, tolerability, target engagement, and any cognitive benefit. And the results showed that the Ambroxol was safe and well tolerated. There was clear evidence of target engagement. However, it did not significantly improve cognition compared to placebo. In advanced Parkinson's disease, oral levodopa often becomes less reliable because it's short-acting and patients experience motor fluctuations, alternating on and off periods, dyskinesias from peaks in dopamine levels. So the goal here was to provide steady, continuous dopamine stimulation to smooth out symptoms and improve quality of life. So the drug device name is foslevodopa foscarbidopa via LEV, a liquid form of levodopa carbidopa, which is given subcutaneously via a small pump, which is worn under the skin, basically like an insulin pump. And this allows for a 24-hour continuous infusion of levodopa. The trial compared continuous subcutaneous infusion versus optimized oral levodopa, and the results were that continuous pump reduced off time by several hours per day, increased on time. Main side effects were mild infusion site reactions, and it did achieve stable plasma dopamine levels, so there were fewer fluctuations. And actually, this product has been approved by the FDA back in 2024. So we're all familiar with traditional deep brain stimulation, which involves surgically implanting electrodes, usually targeting the subthalamic nucleus or globus pallidus interna. These electrodes deliver continuous electrical pulses or fixed setting to reduce tremor, rigidity, and bradykinesia. So the problem with traditional deep brain stimulation is that it does not adapt to changes in the patient's brain activity. It stimulates constantly even when there is no need for that. And that can lead to side effects, battery drain, and less precise control of symptoms. So adaptive deep brain stimulation is the next generation of closed loop system. So it does not just send fixed stimuli, but instead it listens to the brain in real time and it adjusts the stimulation automatically. So how it works? Basically, the device records local field potentials, small electrical signals from the brain regions like the motor cortex or subthalamic nucleus. It identifies beta oscillations which correlate with motor symptoms such as rigidity and swollenness. And when there's beta activity increase, which means worsening of symptoms, the stimulator automatically increases output. And when the symptoms improve, it decreases stimulation. So the device learns how the brain behaves and responds dynamically. The advantages here are that stimulation is only when needed, which reduces overstimulation, like with traditional deep brain stimulation. There are fewer speech or balance side effects, improved quality of life, and longer device lifespan. Focused ultrasound ablation. It is an emerging non-invasive alternative to deep brain stimulation. How it works, so high-intensity ultrasound waves are focused on precise target in the brain, in this case, the globus pallidus internus. The ultrasound energy will then create a small thermal lesion, disrupting the abnormal neuronal firing that causes tremor, rigidity, dyskinesia. And the procedure is guided in real time with MRI, which allows millimeter accuracy without open surgery or implants. So a study published by the New England Journal of Medicine from 2023 which is a randomized controlled clinical trial, basically compared unilateral focused ultrasound pallidotomy to a placebo procedure, assessed improvements in motor function and dyskinesia, and the results, patients who received actual ultrasound ablation showed greater motor improvement and reduced dyskinesia at 3 months compared with the placebo group. There were some adverse effects, mouth speech changes, gait imbalances, facial weakness, which is usually transient. But overall, the procedure was safe, but long-term studies are still needed to confirm durability and safety. Okay, Vibrotactile coordinated reset stimulation. It is a therapy developed by Stanford University by Dr. Peter Das and his team. It's called the Vibrotactile coordinated reset, or VCR stimulation, and it represents a new non-invasive way to modulate brain activity in Parkinson's. In Parkinson's, group of neurons in the brain, especially in the motor circuits, start firing abnormally in synchrony. This excessive synchronization leads to tremor, rigidity, and slow movement. Goal of the therapy is to desynchronize these abnormal firing patterns in other words, to reset the brain's rhythm back towards normal. So the VCR device is a glove basically, and it delivers pattern vibration to the fingertips that are between 100 and 300 hertz. And these vibrations are precisely timed to interfere with pathological synchrony between neurons, a process called coordinated reset stimulation. So the results, the brain motor network becomes less synchronized, motor symptoms improve, and these improvements can persist even after the stimulation stops, which basically suggests long-term neural reorganization. And the procedure, the glove is completely non-invasive and painless, so that's always a plus. Last but not least, the anti-α-synuclein immunotherapy. So a major pathologic hallmark of Parkinson's disease is the accumulation of alpha-synuclein, which is a misfolded protein that clumps in Lewy bodies inside neurons. These aggregates are toxic and they will spread from cell to cell and drive progressive neurodegeneration. So the goal of this therapy is to clear alpha-synuclein aggregates or to stop their spread using the immune system. So the main idea, researchers are now exploring immunotherapy. In other words, using antibodies or vaccines to target and remove abnormal alpha-synuclein. So there are two main approaches: passive immunization, where patients are injected with ready-made monoclonal antibodies that specifically bind to alpha-synuclein aggregates in the brain, and these antibodies tag the proteins for clearance by immune cells or prevent it from spreading between neurons. And there is also the active immunization, vaccines. So instead of injecting antibodies, this approach stimulates the patient's own immune system to produce antibodies against alpha-synuclein. So the results so far, both strategies have proven safe and biologically active, meaning they reach their targets and reduce alpha-synuclein in the cerebrospinal fluid. However, large clinical trials have not yet shown clear clinical benefits, so research is ongoing to maybe refine the dosage, timing, and patient selection. So to go back to why all of this is important, here's a clinical case. Patient, 68-year-old female that has a 10-year history of Parkinson's disease. Main complaint is increasing motor fluctuations and off periods despite optimized oral therapy. So the history, initially, disease was well controlled on levodopa, carbidopa for 6 years. over the past 2 years, developed severe wearing off dyskinesia and sleep fragmentation. Non-motor symptoms are also present, like depression, constipation, mild cognitive slowing. The patient has not yet received deep brain stimulation, and they're currently taking levodopa, carbidopa, rasagiline, pramipexole. So traditionally, the way we would manage this patient is to increase the dose of the oral medications, maybe add a COMT inhibitor or try deep brain stimulation. But now with the approved VIALEV, which is the continuous 24 hours foslevodopa, foscarbidopa, the patient can have a smoother control of their symptoms without the off periods. Before, we could have tried deep brain stimulation that would target the subthalamic nucleus. Now, instead of that, could be tried the adaptive closed loop deep brain stimulation that adjusts to neural feedback. So the brain is not overstimulated and there's longer battery life to the device. Cognitive and psychiatric symptoms are treated symptomatically. Now can also be included one of the immunotherapies, for example, that targets alpha-synuclein aggregation. And always it's important to have the supportive physiotherapy, speech and sleep hygiene. And now to that regimen can also be added things like the Stanford glove that can help to enhance mobility, preserve function, decrease tremor, so the patient can be more independent. So my hope for Parkinson's is ultimately to be able to restore the dignity and independence of the patient so they can again feed themselves, hold the cup without spilling it on themselves, be able to walk to their garden without fear of falling, be able to smile without their smile being masked by the disease. So every breakthrough in research, no matter how small, is a step in the right direction. So these are my resources.